Good morning, everybody. Welcome to our 2019 World Dairy Expo. I hope that you're having an enjoyable time here in Madison. Sorry about the weather. We ordered really nice weather, and then Mother Nature was like, yeah, you're sorry, you didn't, so I apologize. But this morning's seminar, I'm very excited, is about proactive management practices to reduce antibiotic usage on your dairy, presented by Dr. Michael Capel from Perry Veterinary Clinic. The implementation of the Veterinary Feed Directive has led dairy farmers and researchers to discovering new ways to reduce microbial use on farms. New research findings that will be discussed during the seminar identify potential ways to significantly reduce the use of microbials on dairy farms without negatively impacting individual animals or herd health. These findings complement well-documented measures already known for reducing antimicrobial use, such as the importance of disease prevention, proper employee training, development of on-farm treatment guidelines, and judicious use of therapeutic interventions. Dr. Capel is a dairy cattle veterinarian in Western New York, so we're really pleased this is his first trip out to Madison for World Dairy Expo. He plays an active role in a variety of research, including for the pharmaceutical industry and for academic and on-farm projects pertaining to transition cow health, antimicrobial use, and effective treatment regimens. This seminar has been approved for continuing education credits, both in the ARPAS as well as on RACE. So if anybody wanted to get those credits, we have a form out back that you can make sure to fill out. So if you haven't already done so, please silence your phones, and I will turn it over to Dr. Capel. Thank you.
Thank you so much. How does the mic sound? Can everybody hear me in the back of the room okay? Does it sound okay? Super. Well, this is my first time at Expo, and I'm really excited to be here. Wonderful opportunity to share this with you today. I'm going to give you just a little bit of an overview of our practice area and myself, and then we'll launch into more of the meat of the talk. I'm a dairy practitioner in the western part of New York State. I've been in practice for about 20 years. I'm very much a traditional practice with an emphasis on milk quality work. I do a lot of nutrition for the clients that I work with as well. But another avenue of business for me is a lot of clinical research. So I do a lot of clinical applied research for pharmaceutical companies. I do some research for universities, and I'm also involved in a lot of on-farm research with some of my clients, trying to help them find the best strategies, the best management strategies, best treatment strategies for operating their dairies. Our practice has 32 doctors. We have 4 separate clinics in the western part of New York State that encompasses a lot of small animal work as well as a lot of dairy work. We have about 10 to 12 trucks doing ambulatory dairy cattle practice on the road on a daily basis. And this year celebrates our 100th year in business. We were founded in 1919, which is pretty neat when you think about it overall. So we've been in business for about 100 years. Only about 20% of that have I been there. All right. So one of the things that I want to get across today is that our goal really when we talk about decreasing antibiotic use is not to go to some just standard, let's cut antibiotic use by half, or let's cut it to 0 or whatnot. Our goal really is stewardship. There's been some other approaches in other areas of the world, other countries that have said arbitrarily, okay, let's reduce antibiotic use by 50%, or we're going to set some goals and we're going to figure out how we're going to do it later. I think that it's a much better strategy to use evidence-based medicine and use some research and use some management practices to be more proactive about that. And let's figure out the strategies before we figure out what the goals are going to be for reducing use. So I really want to talk more about stewardship rather than just a blind reduction in antibiotic use. So here's kind of what you've signed up for today. If you're in here, there's lots of other things that you could be doing today, so I really appreciate the opportunity to speak with you today and your attendance. Let's see if you all agree with what you signed up to listen to for the next 45 minutes or so. So I'm going to talk a little bit about some of the legislative challenges and some of the public challenges to the dairy industry with regards to antibiotic use, sort of what's coming down the pipeline and what regulations we can expect in the future, both on a national level and on a state level. I'm going to give a little bit of an update on the Veterinary Feed Directive. I know that was a really hot topic for a while, more so in other animal protein businesses than in the dairy industry, but still it did affect us, and we didn't think we would manage through it, and for sure we have, and quite successfully, and I'll talk about that. And then the 3 management opportunities that I'm going to highlight for us on dairies will be using selective dry cow therapy and using pathogen-based mastitis therapy So sort of in those two aspects, going away from blanket use of antibiotics for both of those diseases. And we'll get into that a little bit more. And then finally, highlight some of the recent research and opportunity that might be available for decreasing antibiotic use in the fresh pen, specifically with metritis and other transition cow diseases. So our industry, it seems like anytime you pick up a newspaper, anytime you pick up a magazine, we are under attack these days. People are concerned about our carbon footprint and how we contribute that to the environment. And there's going to be a great speaker at 1 o'clock today who's going to address that. And I highly recommend you attend his talk. He's a wonderful speaker and does an excellent job. People are worried about how good a job we do taking care of our cows. You know, for years in the veterinary industry and the dairy industry, we had a wonderful lofty standard among all professions of the trust that the public had in us. And I think in the last 5 or 10 years, that's sort of eroded a little bit. So I'm not really entirely sure why that is. I'm not really entirely sure it's justified, but it's something we have to work on as well. And then third, relative to my talk, is antibiotic use. The public is worried a little bit about how much antibiotics we use. And this is all protein, animal protein. This would be eggs and poultry, and this is pork and beef, as well as the dairy products that we produce. And might be more of interest to us. But the public's worried that we use too much, and that puts us at a risk for contributing to antimicrobial resistance. And they are worried that potentially some of that residue is still available or still present in their food at the marketplace. So anything that we can do really to lead change and be proactive in this, I think is exactly what we need to do. Antibiotics are a management tool that we have. I think we will be, our use of them will be dictated more and more as we go forward in the future. And I think if we are proactive in part of that discussion, we will be able to lead the effective change rather than just being on the receiving end of that. So I think even though some of these concepts might be new or some of these concepts might be quite divergent from the current practices we are using now, I think they're pretty important for us to think about and also to investigate additional things as we go forward. So here's some history of some of the legislation that's out there. In 2003, the FDA started to really take notice of the antibiotics that we use, and they came up with their list of what they call medically important antibiotics. These are antibiotics that are very important in human medicine, and they said, okay, we know that you use them in animal medicine, and we're just going to start to say, okay, here's the list of antibiotics that are out there that you use in animal medicine as well, and we're going to kind of start to track or at least pay attention to how much you use. That was the first step, really, in 2003. In 2012, we kind of took the next step, and the FDA said, okay, we know that you're using them. Let's make sure that you're using them the right way, and you really shouldn't be using them for performance reasons or production-based reasons. We really only want you to use them for therapeutic reasons. So we're going to kind of start to regulate that. There wasn't any regulation here, but the FDA started to say, okay, we're going to take pay a little bit more attention to how you're using them as well. Really started to increase the concept of having more veterinary oversight. So kind of starting to step away a little bit from over-the-counter use. Sorry for that. 2013 is when the Veterinary Feed Directive, or VFD law, first started to come about. It wasn't enforced at that point in time, but basically it said we're really not happy, the FDA said we're really not happy about performance uses and production-based uses for antibiotics, so we're going to start to get away with them, and we're going to eventually pull away all of the over-the-counter feed-grade antibiotics and over-the-counter water-based antibiotics from the industry's use. So that started in 2013, and then it really ended in 2017 with the adoption of the Veterinary Feed Directive. So on January 1st, 2017, for all animal agriculture industries, there was no more over-the-counter sale of feed-grade antibiotics and no more over-the-counter sale of water-based products. So at that time, in order to use feed-grade antibiotics, you had to have a VFD, which is basically a written prescription. It's a little bit different form, but it basically involves a veterinarian who has knowledge and comfort with your operation, And they are involved in selecting the right production class and the right antibiotic, the right duration of use, and it has very specific guidelines for how you're going to use that antibiotic versus just over-the-counter use, where we had no regulation of that at all. Water antibiotics. Water antibiotics went to prescription only, so they're not under the VFD, but they are also under similar regulation where they require a veterinary prescription. So how are we doing with that? You know, at the time there were a lot of producers, and it really affected some of the other animal protein businesses a lot more than it affected the dairy cattle world. Of course, we can't use any VFDs in lactating animals anyway, so it really only focused on the young stock side of things. But I was surprised how much was actually out there that I, as the veterinarian of the farm, was not aware of because it was over the counter. The FDA published this just a little bit earlier this year and said, here's how we're doing. So this is a results of an audit they had done of the manufacturers and producers, distributors, and all the way through down to the veterinarian and to the dairy as well. And they said we're actually doing a really good job. We looked at 54 farms the year before in preparation. We looked at 130 farms during 2017 during the first year of implementation. And then we looked at half again as many of those farms, a little bit more than that, in 2018. And there was only one instance out of 2018, out of those 230 some odd farms that they looked at, where they actually had to go in and intervene and found some serious flaws. So I think that's a pretty good thing for a large, pretty complicated piece of legislation to come across to make that big a change. I think it was pretty good and shows that our industry was prepared and that we responded pretty well to it. So the FDA basically said, yeah, you're pretty much doing a good job. We're going to increase our oversight on the entire supply chain, because most of those audits were done at the manufacturer and the distributor, so people that probably have to have things in place a little bit more, or they lose their ability to use those products or sell those products. They're going to probably spill down into the veterinary level and into the farm level as well. But at least early on, we think that we're probably doing a pretty good job adopting the VFD. So what do you think it had, what kind of impact did it have on antibiotics? Well, it had a huge impact on antibiotics. This is FDA data, and again, it's from all animal agriculture. So it's from the poultry industry, it's from the swine industry, it's from the beef industry, and the dairy industry as well. So it's all across the board. And you can see that really the amount of, prior to the VFD, the amount of antibiotics that were used were almost exclusively over-the-counter antibiotics, and they were mostly feed-grade antibiotics. So you can see by the yellow bars on here, those are the OTC, or the over-the-counter feed-grade antibiotics. So huge usage of over-the-counter antibiotics. That changed in 2017 to becoming veterinary prescription or veterinary feed directive. But you can see we decreased from the high point, the high watermark of antibiotic use in our country, we decreased about 40% the antibiotics that we used. And then from the next year, we had a 33% decrease in use from 2016 to 2017. I think that's front page New York Times stuff, right? I think that's really remarkable that our industry was able to do that. And I'm not sure that I've heard enormous reports of cattle dying or cattle being sick or whatnot. So we've been able to accomplish that by more intense management of farms, decreasing overcrowding in heifers, adhering to better transition protocols where we get weaning dialed in a little bit better so we don't have transition disease, looking at vaccination programs, all of those sorts of just good management practices that we probably needed to attend to, that without the help of over-the-counter feed, we really had to do a better job from. And I think we should really be proud of the reduction of antibiotic use that we've had overall based on that. So I think that's a pretty good story to tell for us. What's coming next from a legislation standpoint? I think fairly quickly we will lose the all over-the-counter antibiotics. So anything that you would go down to Tractor Supply or whatever local store, penicillins, I think you can still buy gentamicin there if you want to do that, which I don't think you should. But anyway, all of that sort of stuff is going to become veterinary prescription at some point in time, and I think the fairly near future. There's some intramammary therapies, there's certainly plenty of injectable antibiotics, but in the US at least, I think those will all become veterinary prescription within, I don't know, over the next 5 years or something of that nature. And this guidance for the industry 263, basically put out by the FDA a couple of years ago, is starting to outline a process for that happening. So that's something that we're going to have to be ready for. They're also going to update their list of medically important antibiotics, and they're going to update their surveillance and their monitoring of those medically important antibiotics as well. So that's something that's going to come down the line. And again, medically important antibiotics are antibiotics that are used and really critical in the human health industry that we also use. We're not talking about ionophores and some of those sort of products like Rumensin and Bovatec and whatnot. We're talking more about injectable antibiotics or intramammary antibiotics, penicillins, tetracyclines, cephalosporins, things of that nature. So that's more our medically important antibiotics. And then at some point in time, and again, this third point doesn't relate so much to the veterinary industry, but the feed grade antibiotics that are out there under the VFD, lots of them don't have a defined use of duration. So feed for 5 days or feed for 30 days. So I think that's going to go his way as well as the FDA encourages our industry to come up with guidelines for how long we should feed those products. So that's sort of what's coming. So, you know, we've been at a place where we could kind of do whatever we wanted, and we're sort of moving to the place where we're a little bit under the microscope, a little bit more from a government standpoint, to a place where, well, you can't do that anymore, and now you have to have your veterinarian involved. So I think we're just going to see this steady march of more and more regulation, which really, I think, really brings home the point that we have to be part of this discussion and how we use antibiotics, and we have to help to sort of auto-regulate our industry before they continue to do it for us. I think we want to be part of that discussion rather than being led by the discussion from people who don't know our industry as well as we do. Local legislation. So there's been local legislation in California and Maryland that's already passed. Local legislation in New York this year almost came to the point where it said you can't use any antibiotics for a non-therapeutic use. Now remember, we already can't use them for performance-based claims or production-based claims, but I guarantee that most of the producers in this room use them for non-therapeutic uses all the time, and that would be dry cow therapy. So in certain states in the country, there is no longer dry cow therapy, and New York came within about a fraction of a second on the legislative floor this year to losing dry cow therapy as well. So some of these things are definitely coming, and we have to do the research trials. We have to figure out the management interventions that we can do to be ready for it when and if they do come from a legislative standpoint. So we're going to shift over now and we're going to talk about our management steps as I outlined them before. And although the focus of this talk is on changing the way that we treat animals, no talk on antibiotic use would be complete without at least having some discussion about prevention. And the best way to reduce antibiotic use is to reduce disease, right? We just don't want to have mastitis. We want to have metritis. So we need to do all of those proactive steps ahead of time. And I certainly don't want to dismiss that, although it's not going to be the focus of the rest of the talk, okay? There's my prevention disclaimer slide before we move on to the rest of it. So where should we start? Well, I think in the dairy cow, we should certainly start with using mastitis and looking at how we treat mastitis. More than 60% of the antibiotics that we use, according to data from Wisconsin and some from New York, California, more than 60% of the antibiotics that we used are directly related to either mastitis treatment or mastitis prevention. So I think that provides us with the largest opportunity to make an impact in reducing antibiotic use. 2/3 of that, 60%, is specifically to dry cow therapy. So these are cows, as you know, that we're treating. Some may require it and some may not require it. So I think we're going to dive into that a little bit and how we may be able to change that. In the 60s, blanket dry cow therapy was this new revelation that the dairy industry, the national mastitis came up with, the veterinary community came up with, and it was really revolutionary. It's probably one of the most successful things that we brought in place to improve udder health. A lot of cows were infected at that point in time, and it was very, very successful at improving udder health. Treat all 4 quarters on every cow at all the time. We were so successful as a veterinary industry and as a consultant industry that in getting producers to adopt that the NOMS data in 2014 said that 93% of all cows in the US have dry cow therapy utilized on them, and that's over 80% of the farms. So 93% of the cows and over 80% of the farms. I'm not sure as a veterinarian that I could get 90% of my clients to do just about anything, right? Outside of maybe feed corn and milk their cows, right? So it's just not, it's astounding at how successful we have been at implementing dry cow therapy. However, now we're going back to the well and saying, hey, you know what, that great thing that you all wanted to do, maybe we shouldn't do it anymore. And maybe we should stop doing it as much as we're doing it. And that becomes a little bit more of a contentious argument because we've set it up to be so successful and it's been so widely adopted. Part of the reason why I think that it fits in nicely today as compared to 20, 30, 40, 50 years ago is that more of our cows are healthy than they used to be. If we look at some studies, they've said that 44% of cows and 85 actually were culture negative, which means the other part of that was culture positive at dry off. A lot of need for dry cow therapy in that world. Now we're closer to 73 to 95%, according to some estimates, are culture negative. So maybe we don't need them in those cows. Our bulk tank somatic cell, much better than it used to be before. And the percent of herds that are super high or have cows that are super high for 100,000 and up is less now than it used to be before. So I think the overall udder health picture, due to all the hard work that you guys do every day, is much, much better, and I think it primes us a little bit better to make this transition. So how long have we been dabbling with this? Well, this is an Australian study. It was done in 2013, and it basically looked at all of the different trials that had been done on some sort of selective dry cow therapy prior to that time. And they found 12 different studies that involved the use or compared using an intramammary antibiotic and an internal teat sealant, which has been a wonderful addition to the udder health picture, and comparing that to using just a teat sealant alone. And in all of those 12 trials, they all suggested that both of those strategies, antibiotics and a sealant versus a sealant alone, were effective at decreasing new infections at calving, but also important at decreasing new infections for the beginning of lactation. So those cows didn't get mastitis any different over the dry period, and they didn't freshen with mastitis any different. They did say that the dry cow tube or the antibiotic reduced intramammary infection in the cows that were high. So I think that makes pretty good sense. The cows that were infected did get better with it, but the rest of the cows, there really wasn't much of a difference in it. So it started to plant the foundation for further work that said, okay, maybe some cows are high risk and they need antibiotics, but the rest of them are low risk. And now we have to work to identify which is which and make that management strategy at the time of dry off. And chop your corn when it's raining and breed your cows and get to Expo and all the 6 million other things that everybody has to do on a regular basis. So this is a recent study. It was a multi-state and multi-collaborator study and involved people from New York, Iowa, California, Minnesota for sure. And it looked at 7 different herds, larger herds in general, looked at about 1,300 different cows and a variety of bedding substrates and a variety of different vaccination protocols. So it looked kind of across the board. And what I'm planting the seed here is that these are herds, right? These are not special herds. These are not super high managed herds. These are just herds that are out there that probably have generalizability to the majority of the dairy industry. And prior to this study, the group at Cornell had done a lot of research on dry cow therapy, looking at using test-day somatic cell and number of mastitis cases to figure out who was high risk and low risk. The University of Minnesota had done a lot of work using some culture data at dry off and saying, okay, we grew bugs, we didn't grow bugs, and if we grow bugs, we're high risk. If we don't grow bugs, we're low risk, okay? So this trial wrapped that all together. So they had 3 treatment groups. They had the group where everybody got mastitis or dry cow therapy and a teat sealant. They had the Minnesota group where everybody got cultured 2 days prior to dry off, and at the quarter level, if they grew bugs, they got a tube, and if they didn't grow bugs, they didn't get a tube. And Minnesota developed on the right side of the screen here, you can see this nice little plate. If they had growth, any type of growth, they didn't care what it was, we put a tube in. If we didn't have growth, we didn't put a tube in, okay? So we've got control where everybody gets something. We've got a control where only quarters that have growth get something. And then we drop down to Cornell's model, which was also compared in this study, of saying, okay, if we're over 200,000 at any time during the lactation, if we've had clinical mastitis within the last 14 days, or if we've had clinical mastitis 2 or more cases during lactation, we're going to call you high risk. So Minnesota's requires a little bit of work, a little bit of effort ahead of dry cow. Cornell's doesn't require any work or effort, but it does require that you do monthly test day, and not everybody does that anymore. So 2 different strategies looking at how we make the decision for who's high risk and who's low risk. And if we looked at the results of that, they reduced antibiotic use by 55%. So that's how many cows were in the low risk group, both the culture-based and the algorithm-based one. So that's a pretty huge reduction in antibiotic use as well. And that was without any decrease in production the next lactation, any decrease in clinical mastitis, any decrease in dry cow mastitis. So it was all of the production parameters that we would worry about. There was no difference in those production parameters when we treated some of the cows with sealant if they were high risk, and the other ones we didn't treat at all. So pretty great stuff here, right? It starts to set the concept that we can use some steps with some data on the farm or with some additional work to identify cows that are low risk and identify cows that are high risk. Just treat the high risk cows and don't treat the other one. And again, everybody in this study got an internal teat sealant. It's just that the high risk ones got antibiotics and the ones that were low risk didn't get antibiotics. And I'm kind of glossing over some of the specific detailed results. I can answer more questions on them later, but I want to hit some of the high points and just introduce the concept as we go along. So here's sort of a slide that the researchers from that trial and myself put together in efforts to get something in front of you guys for this talk. But herds that I think would be reasonable candidates for using selective dry cow therapy, again, establishing high risk, treating them, and low risk, just using a teat sealant, would be herds that are pretty healthy in general. And we'll use bulk tank somatic cell as a surrogate measure of that. So herds that have a low bulk tank somatic cell. Herds that have limited contagious mastitis. Certainly if you have a history of strep ag, I wouldn't consider it at all until you got that out of your herd. I would probably consider it if you had some Staph aureus, but probably not too high a prevalence of Staph aureus. Herds that certainly had an excellent relationship with their veterinarian and were able to follow treatment protocols. Herds that would be willing to do some surveillance, so herds that would look for the presence or development of some bugs that we needed to be worried about, potentially contagious bugs and whatnot. So I'd want to make sure that we were able to do that. And certainly just the simple things, herds that did an excellent job at dry off with dry off technique, and herds that had really clean and excellent dry cow facilities. If your dry cows are overcrowded by 50%, it might not be the best thing for you to do. If you're not the one who's involved or you're not training your people who are involved in dry cow therapy, it's probably not the thing you should do as well. So there's some just simple management fundamental things that we need to have in place before we go forward and implement as well as just some overall herd risk things to consider. So I'm going to leave dry cow therapy talk quick now. I think I'm well into my time. So we'll talk next about pathogen-based mastitis therapy and try to see if we can get through the majority of that before the end of my time and then allow for some questions. So this is a slide from well before my time, but some of you in the room may remember it. It used to be a big decision as to what tube we were going to put in clinical mastitis cows, right? There were tons of tubes on the market, including plenty that your veterinarian made up in their bathtub at home and sold to you and put in these little squeeze jet tubes up here, okay? I think we've evolved really far in the use of how we approach clinical mastitis. We've gone from a blanket therapy, treat them all, and treat them for as long as they have clinical mastitis, which probably resulted in significant overuse of antibiotics, both in cases and on an individual case basis based on duration. For a little while, it was in vogue to treat nobody, especially in the western states. And we said, okay, well, we don't think there's a good response, so we're going to treat nobody. And that's pretty effective unless you have different types of bacteria in your herd, and that can grow up and sort of smolder in the background until it becomes a bit of a problem. So I think we've sort of settled in as our industry into saying, okay, let's figure out what type of mastitis it is and treat it based on culture result. And there's really great evidence for the last 10 years for this sort of a strategy. This is a really complicated slide, not intended to put you all to sleep, but intended to tell you that there are a lot of similarities in the types of bacteria that different farms have. Okay, so if we look at these are 8 different farms that are here, and these are farms that are on regular culture with the quality milk production services through the diagnostic lab at Cornell University. So these are New York farms, but I don't think they're unlike Wisconsin farms or California farms or anywhere else. They're good-sized farms, 500 cows to up to 5,000 cows, so pretty good number of farms. And these pie charts here are the types of mastitis that they have. And if you look, this gray color is conserved throughout, and that's the amount of no growths. When we do culturing, we typically get 25 to 30% no growths, and I think that's normal and justifiable. You will see some companies that will market the thought that there should be growth, and there isn't always growth. When we see clinical mastitis, that is when inflammation occurred. It doesn't mean that's when infection occurred. So the infection may completely be cleared up. If your milkers didn't find it for 3 or 4 days, the infection may be cleared up and completely gone at the time that you diagnose the mastitis. So it's completely and fully acceptable to have 20 to 25, maybe up to 30% no growths, and I see that consistently throughout my practice. And I don't think those animals need antibiotics. In fact, there's some data that suggests that if we do treat them, there's a negative impact, because maybe there are some bacteria that we can't detect yet that are actually normal and healthy in their microbiome. So the overutilization of bacteria and antibiotics in those no-growth cow is probably a negative. It probably impacts them negatively, both production from a mastitis standpoint. So if you start a culture program, if you're involved in a culture program, accept no growths. They are part of the model, and they are completely normal. We shouldn't always find bacteria. Just because we find pieces of bacteria doesn't mean we have an active infection now at this specific time. Streps are in blue, so there's a variety of the different streps that are there. Coliform bacteria are in orange here, so coliform bacteria usually 10 to 15%. Streps might be 30% or so of the bacteria. It's a little subtle variations on all of these herds, but they follow sort of the same storybook on a regular basis with a little bit of variation. So I think really what I'm trying to suggest is that the discussion shouldn't be necessarily what to treat with, although we can get into that discussion as well. It should be more who we're going to treat with antibiotics as well instead. How does this work? It works with diagnosis of clinical mastitis up at the top. We take some milk culture and we put that animal in the hospital pen. We're not allowed to ship her milk anyway because it's abnormal, so she goes to the hospital pen, and we wait on intramammary therapy until that culture result comes back. Based on the culture, which could be done on farm or it could be done at a reference lab if you're lucky enough to be close to one, we can say, hey, she's got really bad mastitis, mycoplasma or something like that, and she needs to see the guidance counselor and develop a different career in the beef industry and not be in the dairy industry anymore. We can determine who doesn't need antimicrobial therapy, the no growths, the coliforms, and you can have that discussion with your veterinarian as to what he or she feels is going to respond to antibiotics, and who we're going to treat from an intramammary standpoint. So I think that's sort of the algorithm of how it will work on the dairy. Why it will work, about 85% of all of our mastitis cases are mild and moderate cases. These are cases of mastitis that the cow is not systemically ill. Only about 15% are systemically ill. So I think it's really important that we're going to treat the systemically ill cows from day one. And I'll talk just a freckle about that. But the mild and moderate cases, we actually should delay until we get our culture result back. There's no data suggesting that an extra day or two of waiting for her to have her culture back is going to decrease our cure rate in her. So we're not going to worry about 24 or 36 hours to get the time to get the culture result back. So that's fine. And I think it's really important because we're going to minimize the number of animals that we're going to treat. So that trade-off is reasonable. So in my herds, I treat mastitis as 2 separate diseases, diseases of the cow and diseases of the udder. If the cow is clinically ill, and again, most of the data from all over the country suggests that that's probably only about 15% of cows, and you guys know these cows. They're the toxic cows. They're classic, they're down, they're really sick. We're going to treat them up front, day one, regardless of what bacteria comes back. And talk with your service provider, your veterinarian, to figure out what the best choice is for your herd and for their comfort level. But it's going to probably be mostly supportive therapy, not necessarily intramammary therapy. Aggressive fluids, anti-inflammatories, maybe an antibiotic, but that's going to be a discussion that you're going to have for your specific farm. And then the udder, we're making a separate choice. So I actually record these as two separate diseases in dairy comp. I have two separate diseases that are in there that make accounting and make drug accounting a little bit easier. So we're going to treat these right away, and we're going to wait for our culture result to treat these to figure out, do we put a tube in or don't we put a tube in? There's some really good peer-reviewed literature out there from California, from Minnesota, from Wisconsin, from New York, that suggests that this works pretty well, comparing herds that, in a subset in the herd, comparing control and treatment groups where some of the cows got treated immediately with antibiotics and some of the cows waited for a culture to come back, and the ones that had the bacteria, streps most specifically, that they thought would respond to antibiotics, got antibiotics right away, and the cows that didn't get antibiotics. So when we compare all of those, there's no difference between pathogen-based therapy programs and blanket therapy-based programs with respect to milk production, with respect to linear score, with respect to all of those production parameters, culling and death loss that we would be worried about. So there's quite a bit of data out there that shows that we can pretty effectively reduce antibiotic use 60 to 70% in clinical mastitis by using a pathogen-based approach. And again, I think that's super news that should be front page of magazines. You know, it's wonderful reduction without the downfall of any negative impact on the cows. So pathogen-based treatment decisions, I think they have the opportunity to save us tubes and labor. They have the opportunity to decrease risk of residues in the tank because we're not using so many antibiotics. They have the opportunity to tell the public that we're doing a bit of a better job by using less, so we're not so much of the problem in terms of antimicrobial resistance. They're better for hospital pen management because you're going to have animals in there long. Most of these studies say that the animals that were on a pathogen-based mastitis treatment program were in the hospital pen about an average of 3 less days. So there's going to be more milk for you to sell. And it actually nets out to be somewhere around $30 per cow in the herd per year. So herds of 1,000 cows can save up to about $30,000 a year, mostly driven by increased milk sales, but also driven a little bit by decreased antibiotic cost and a little bit of decreased labor cost. Okay, a bit of a whirlwind tour on pathogen-based therapy. I've got 5 minutes to talk a little bit about fresh cow therapy, and then I want to make sure that we do provide some time for some questions and whatnot, since I've gone through some of this material kind of quickly. Again, if we think about decreasing antibiotic use, I chose mastitis as the first disease to talk about today because it represents the largest amount of antibiotic use on our dairies. If we stick with the lactating cow, I'm not talking about the replacement calf, but we stick with the lactating cow, probably the next biggest opportunity that we have after that is in the fresh pen, right? Either right before or certainly within a couple weeks afterwards. Most of the disease that's going to occur to our cows is going to occur at that point in time. Outside of lameness and mastitis, it's all kind of wrapped up in that first 2 to 3 weeks. So if we think about managing disease, we're going to be thinking about managing that part of the lactation. And if we think about more disease occurring there, then dairies have to have a really quick and efficient and effective and repeatable screening method for getting into the fresh pen, identifying who's sick without interrupting their day too much. We're not going to lock up cows for 4 hours, right, in order to temp and treat everybody. So we want to get in, we want to figure out who's sick, and then we want to get out of the fresh pen. And I think that's pretty critical, and there's some good publications trying to characterize what is being done out there. California has probably some of the best work, but I think their herds are generalizable again to the rest of the country. So I think we can use that data to talk about what's happening on an industry level, not just on a state level. And they published a nice study in 2016, excuse me, where they evaluated what dairies do in the fresh pen. How do you look at cows? How do you lock them up and whatnot? And how long are they locked up? And all of those sorts of things about What are we doing to screen our fresh cows for disease? And they said that there was no consistent method. Everybody does everything a little bit differently, and there's a lot of use of just subjective tests. Her ears were drooped, we called her sick. Her eyes were sunk in a little bit, we called her sick. So there was a lot of really subjective, not objective, but subjective measurements that people were making to determine when their animals were ill or not. I think that's okay as long as there are well-trained people. And I'm not suggesting that the well-trained sort of classical herdsman is not appropriate here, the cow guy who's known their cows inside and out, but I find fewer and fewer of them in my practice all of the time. And I think that we need to do a better job of training their replacements as we go forward, and also using some data, rumination monitors, activity monitors, production, some of those sorts of things to help to identify those sick cows. So again, we're not relying on a skill set that may or may not be available on our dairies. If we look at people who use temperature-based only methods for determining who should be treated and who shouldn't be treated, there's some good data out there that says maybe as much as 60 or 66% of animals will have a fever in the absence of any disease within the first 10 days. So these blind temp and treat programs that we used to use probably result in a considerable overuse of antibiotics as well. So I think what we need to do is we need to set the stage for looking at more specific criteria for when we establish whether a cow does have disease and requires antibiotics. A little bit alarming looking at that study. Again, from that same data set about some work that they published about 2 years later from these 45 herds in California. And again, these were herds that were in the range of, I believe, about 500 cows up to about 9,300 cows. So some big herds in there, but not all big herds. Some people used antibiotics, about 25% of people, just based on abnormal vaginal discharge alone. I think that has the potential to relate to significant overuse. About 30% used antibiotics for metritis again. This is for metritis based on some health concern and a fever, but with no attention to vaginal discharge. So again, I think it was probably a bit of may relate to some overuse there as well. About 20% of herds used antibiotics based solely on fever with no attention to other concerns about the cow or other physical exam criteria. So again, based back to that previous slide, fever is a normal or can be a normal process as that cow cleans things up in her body. So the presence of a fever alone is not indicative of a deficiency of antibiotics. Sort of a bit of a catchphrase that I'll use with some of my producers. And the industry accepted definition for metritis. If you were going to go to the FDA and say, I have magic foo-foo dust in this bottle and I want to get it approved for metritis, the FDA would require you to have a case definition of an enlarged uterus, a fetid and watery discharge, and a fever of 103 or higher. So I think that's a pretty good definition for it, and that's what I use for my clients when I'm training people in the fresh pen. So I think there's certainly some opportunity for us to be a little bit more scrutinizing about how we train our employees in the fresh pen, if it's not us personally. I think there's some opportunity to have people work with their local veterinarian to get in there and improve physical exam diagnostic skills, teach people some of the fundamental techniques of physical exam and diagnostic skills, and then also to switch over into diagnosing disease more specifically and then appropriate protocol selection for treating those diseases. So this is a bit of a personal case that I had, and this is about a 1,200 cow dairy that I work with, but I only visit them on a once-a-month basis. It's not a one where I have a routine conventional herd health role with. And I run a monthly report for them, and we're kind of cruise along at a metritis rate of in the neighborhood of about 8%, so pretty normal. And then one month we had about a 4-fold increase in metritis, and I was, okay, we've got to contact the nutritionist, and we've got to go down the whole algorithm to figure out what's going on with these cows. Well, when I got to the farm and I actually looked around, the farm, there was nothing that had changed except for a new employee in the fresh pen. And the new employee's case definition for metritis was different than the previous employee's case definition. So all of a sudden, no animal health changed. However, we changed our detection level for disease to where we called more cows metritis cows than we had before. And I think this happens pretty routinely. Maybe this is a bit of a large and a extreme case of it, but I think this happens on a fairly routine basis, depending upon maybe somebody else is in for the weekend and they're not the person that's there on the weekday basis. But we used a lot of extra antibiotics in this herd, and there was a lot of cost to this dairy, depending upon their antibiotic choice, and whether that involved dumped milk or not. They might have been up to as much as almost $200 per case for that. So all of that extra dollars that they spent there in dumped milk and antibiotics would have been much better spent by bringing somebody in to train that person. So it really highlighted to me the opportunity for dairies to utilize veterinarian and utilize other agri-professionals to get in there and do a lot of on-farm training for their staff that is in the fresh pen, because they have a lot of power to be able to use antibiotics, not use antibiotics. They can change a lot of factors on the farm, and I think it's really critical that we educate them, and we were involved in training them. So training protocols, just kind of briefly as we end here, I think it's pretty important that we need to train our staff on diagnosis. We need to have them make sure that they are able to do all of the specific techniques that they need to do to be able to make the diagnosis of metritis or make the diagnosis of a displaced abomasum or ketosis or those sorts of things. I think we need to make sure that they actually know how to read a thermometer and they know how to use a ketosis test. And I think we need to make sure that they know how to read too. I think that happens a lot more than we think when some of the larger dairies that may have somebody who left the farm, maybe somebody comes into that farm who we haven't trained them appropriately. I think there's a lot of opportunity for us to be in a better situation with them. And then certainly how to educate them on making treatment decisions as well, and how to actually give medicine. So I think there's a lot of opportunity for us to get into the fresh pen and improve our detection principles and improve our decision for how we diagnose disease and then how we treat that disease afterwards. So, excuse me. Treatment protocols, every one of the dairies that I have, and I think this will be mandatory at some point in time in the future, but every one of the dairies that I have has on-farm treatment protocols. They clearly define the disease that's being treated. They clearly defined the antibiotics, the pharmaceuticals, and the medicines that we want them to use to treat those diseases. They clearly define withholding, and they clearly defined when to call an animal a failure and when we should drop down and utilize the next therapy. So I think that's pretty critical. If you don't have those on your dairy, I would really encourage you to work with your veterinarian and a professional to get those in place. So bringing it all around, just a freckle over time here, I think there's a huge opportunity for us to decrease antibiotic use and be better stewards of antibiotics by using pathogen-based mastitis therapy and by using selective dry cow therapy on farms. I think there's more milk that we can sell, and I think we can have a better story to tell the public that we are actually using antibiotics in the way that we want to be use them, in a way that we're proud to be use them before we lose that management tool. I think training is very critical for our farms, both from the standpoint of diagnostic accuracy, minimizing the impact that our evaluations have on that cow's life, and minimizing our use of therapeutics as well. And I really think that the farms would benefit from having a discussion with farm staff, but also the veterinary professional they work with as well, to make sure that all of that is in there. So that's my whirlwind tour of a couple different topics, and I'd be happy to take any questions. And again, I really appreciate everybody attending today. There's a lot of things that compete for your time and interest here, and I really appreciate that you devoted the hour to my talk. Supposed to be somebody with a mic. Okay, very good. Super. So thorough and eloquent, no questions. All right. I'll stick around afterwards for a little while if anyone has some more detailed questions that they didn't want to bring up in front of the group. So thank you so much.